to our continued Booster Blitz series. I'm really excited. We have a great speaker for you today that's going to be talking about antipsychotic reductions and unintended effects. Josh and Margie are on the road today, so I'm filling in. So we'll do a few housekeeping tasks before I introduce Dan. But yeah, so Dan, if you can advance the next slide. So we are the iPro QIN-QIO. We are federally funded Medicare Quality Innovation Network Quality Improvement Organization. We are one of 12 regional offices. Under the umbrella of the QIN-QIO is iPro, which serves New York, New Jersey, and Ohio, Health-Centric Advisors, which covers the New England states, and Clarent, which covers Maryland, Delaware, and the District of Columbia. So if you've heard of one of us, you've heard of all of us. Next slide, please. We always start with a COVID update, and so again, hospitalizations as of the 6th of May are down again 15.1%, with the 7-day average at about 1,200, which is awesome. Bivalent booster, we've hit the 56 million mark. We were doing 55 point for the last couple of weeks, but we're at 56 million for folks who have received an updated booster. Almost 43% of adults 65 and older receiving the updated booster, and NHSN still reporting we're at a 54% rate for the data that's reported to them for nursing home residents. As far as the variants, the XBB strain continues to be the most dominant, and I know you all have heard about the 1.16 strain, which is the latest concern. It is up, increasing a little bit at 12.5%. It has a name now, Arcturus. Very transmissible, but it doesn't seem to be any more serious than these recent strains that we've had. And of note, conjunctivitis seems to be a symptom that pediatricians are seeing in children. So COVID never ceases to amaze us and keep us on our toes. Next slide. Just a reminder for folks, and I will put it in the chat, to look at the interim clinical considerations for the use of COVID-19 vaccines that are currently authorized. A wealth of information, and just, so folks know that considerations for folks 65 and older to receive that additional bivalent dose. It is optional, but if it's been at least 4 months after that first bivalent dose, then it really is important for a conversation with a healthcare provider, depending on their underlying medical conditions and age, that this is really a good choice to make. But the monovalent vaccine is no more, so the bivalent dose is what we have for the mRNA doses. So again, I encourage folks to visit that site, and I'll pop it in the chat. Next slide. And without further ado, I'd like to introduce Dr. Daniel Harris. He is a geriatric pharmacoepidemiologist and health services researcher. His research is focused on generating real-world evidence of medication use, safety, and effectiveness among older adults and persons living in nursing homes. His work to date has largely focused on documenting medication substitution as a potential consequence of efforts to reduce antipsychotics in nursing homes. Dr. Harris co-leads a large National Institutes for Aging funded program of research that investigates COVID-19 vaccine safety and effectiveness in subgroups with increased frailty in Alzheimer's disease and related dementias. He completed his PhD in epidemiology at the University of Toronto in 2022, and MPH from Brown University in 2018. So welcome, Dr. Harris.
Thanks so much, Mary Ellen. It's great to be here, and it's good to see everyone, at least virtually. So I'm excited today to talk about what my dissertation was on, which, as Mary Ellen described, is largely related to antipsychotic reduction in long-term care homes. And this pertains both to the US, but all of my work is related to, it was conducted within Canada. As you can see, I have a game of whack-a-mole. So as a fun exercise, you'll see various moles pop up throughout the presentation as just a bit of fun. So I have no disclosures or conflicts of interest for this presentation. And my goal for today is just to give everyone who's probably very familiar in this room just a brief overview of antipsychotic use in long-term care and efforts to reduce their use, and then spending most of the time focusing on those potential unintended effects of efforts to reduce antipsychotics in long-term care. And as I mentioned, this is work that comprised my PhD dissertation. So I'll take everyone through just 3 studies that I had conducted, where the first study just looks at patterns and time trends in psychotropic medication use and relevant diagnoses, or diagnoses that are used to define appropriate antipsychotic use in nursing homes. This is this top study here. Study 2 then looks at variation across long-term care facilities in the rates of change in those over time. So how do facilities differ in their use of trazodone, for example, over time, and how do they differ in their coding of diagnoses like delusions over time? And the last paper looks at specific changes in which drugs may be initiated over time, where perhaps prior to antipsychotic reduction efforts, antipsychotics were initiated for dementia-related symptoms, but then after those reduction efforts, drugs like trazodone then kind of became more prominent as an initial therapy. So I'll take us through these 3 studies, and I'm happy to take questions in the chat and at the end of the talk. So as I said, everyone in this room is very familiar with this, but so concerns about antipsychotic overuse and misuse in nursing homes really dates back many decades, and I have an early paper by Ray and colleagues here highlighted. And these medications are commonly used to treat the behavioral and psychological symptoms of dementia. So this includes things like agitation and psychoses. And these medications do have the largest evidence base relative to other psychotropics like trazodone or gabapentin, for example, for these symptoms. But the clinical trial evidence would show that they're actually that they're modestly effective. But over time, what we've found is that these drugs also increase the risk of various adverse events. So things kind of on the things like excess sedation and falls, but also sudden death in older adults. So following kind of this documented overuse of antipsychotics in nursing homes and the associated risks of these medications, we've entered into what I call the modern era of antipsychotic reduction. And in the US, this came via the Partnership to Improve Dementia Care. And this was launched in 2012. And this was hosted with a bunch of initiatives that aim to reduce the use of antipsychotic medications in nursing homes. And in Canada, there was something similar that was launched in 2015. And both of these are comprised of multiple different types of interventions, much of which are driven by the quality improvement networks in the US, as well as in Canada, and the public reporting of potentially inappropriate antipsychotic use. And this is generally defined as antipsychotic use in the absence of a qualifying clinical indication. So in the US, this is generally a diagnosis of schizophrenia, Huntington's, or Tourette's. And in Canada, this is schizophrenia and Huntington's, as well as symptoms of delusions and hallucinations. So it's a bit of a broader definition in Canada. And just to pull up some data from the Centers for Medicare and Medicaid Services in the US, we see that following the launch of the partnership, we do see a decline in the use of potentially inappropriate antipsychotic use in nursing homes. There has been a leveling off, as you can see, in more recent years, and this is kind of actually maybe increasing. So there are some questions about how low we can go, and we can certainly talk about that. But then in Canada, we also see something similar, where the prevalence of potentially inappropriate antipsychotic use in all of Canada in 2016 was going down quite linearly, and then as well as in Ontario specifically in this bottom line. But there are questions about the potential unintended consequences or the unintended effects of efforts to reduce antipsychotics in nursing homes. And one of them is medication substitution, or the switching of antipsychotics with another type of psychotropic. And the other one is changes to diagnosis coding, or increases in those diagnoses that are used to define appropriate antipsychotic use. And there's some evidence of both of these happening in nursing homes. So on the left, I have a figure showing possible medication substitution in Ontario, where in the blue line, we see overall antipsychotic use declining over time following a newspaper report of antipsychotic overuse occurring alongside increases in trazodone. And trazodone is an antidepressant, and when you look at the qualitative evidence, we do see that some folks use this they do use this for dementia-related symptoms. And on the right, we see that there's also been changes to diagnosis coding. And in the US, much of the conversation is centered on increases in the schizophrenia diagnosis in long-term care. And this is a bit surprising because by the age 65, we really wouldn't expect to see incident schizophrenia. And there have been reports that show that about a third of folks who have a schizophrenia diagnosis in nursing homes didn't have that previously in their claims. So these are important to keep track of for a few reasons. In terms of medication substitution, it's important because the potential alternative drugs don't have as much clinical evidence of safety and effectiveness for dementia symptoms. So there's some questions there. In Canada, we also don't track or monitor drugs like trazodone. We're only tracking antipsychotics. So you could be potentially missing psychotropic medications. So it's important to keep track of medication substitution, but it's also important to keep track of changes in diagnosis coding. And the reason is because if we see reductions in potentially inappropriate antipsychotic use, it becomes unclear whether those reductions are driven by deprescribing, which is the ultimate goal, or it's driven by increases in those diagnosis codes. So this could potentially mask antipsychotic use in homes, and we wouldn't be able to track that from a public health perspective. So in Ontario, I'm going to then take us through 3 studies. So this is study 1, where we looked at the prevalence of these antipsychotics, antidepressants, anticonvulsants, and benzodiazepines over time. And we can see that over time, antidepressants are the most utilized medication, and about 60% of long-term care residents in Ontario were receiving an antidepressant medication. Antipsychotics are highlighted here in orange. We see that the cohort started at about 35%, but then declined over time. It was quite stable at about 25%. But the other trend that we see is anticonvulsants are also increasing, and this is largely driven by gabapentinoids and valproate. When we stratify this by dementia status, we see that antidepressants are actually increasing more rapidly among persons with dementia, which is consistent with possible medication substitution. But interestingly enough, we actually see that the increases in anticonvulsants are most concentrated in people without dementia. So that kind of shows that maybe this drug isn't used as an antipsychotic substitute, at least in Ontario. But what's most striking here is when we look at the change in those diagnoses. So when we look at, for example, the prevalence of schizophrenia and delusions, that they're quite stable early on in the cohort. But after various interventions like public reporting, we see a clear increase in their documentation. And we can see that these increases are actually more pronounced among persons with Alzheimer's disease and related dementias, where the increase in the prevalence of these types of diagnoses are really increasing more rapidly among people with dementia, and even more rapidly among persons with the more severe forms of aggressive behaviors. So this again shows us that a potential unintended consequence of efforts to reduce antipsychotics includes this change to the way that certain diagnoses are documented. And when we look then across, well, how do these trends vary across facilities? What we did is we ran a series of models that looked at each facility separately. So each of these gray little dots here represents a unique nursing home in Ontario. And on the y-axis, we've plotted the rate of change. So if you're above 0, you're increasing over time. And if you're below 0, you're decreasing over time for each of these 3 outcomes. So we look at their change in potentially inappropriate antipsychotics, their change in antidepressants, and their change in those relevant clinical diagnoses. Those are things like delusions and schizophrenia. And we can see that on average, in this black line, most nursing homes were decreasing in their use of potentially inappropriate antipsychotics. And that supports what we've just seen on the prior slide. Well, there's quite a bit of variation here in the rate of how nursing homes are doing this. Although on average, most nursing homes are increasing in their antidepressant use, it's quite tight. Nursing homes are quite similar in how much they are increasing. But you can see here with the relevant indications, nursing homes are very variable in how they're changing in their coding over time. This is you can see how spread out the dots are, where some nursing homes are really increasing in their use of those diagnosis codes, while some are actually declining over time. And when you ask homes how they have reduced their use of potentially inappropriate antipsychotics, you sometimes get answers like this, where this is a particular home where they said that we attribute a significant part of our success in reducing potentially inappropriate antipsychotics to improvements in our coding practices. So some homes have actually made strides in trying to improve the detection and diagnosis of things like delusions, while others aren't as clear in how those and whether this is a result of antipsychotic reduction. And we can see this clearly in how much variation there is in the rates of change across nursing homes for this particular field. But then what we did is we decided to correlate these two outcomes together to see if nursing homes rates of reductions in antipsychotics is correlated with their rate of increase for antidepressants or rate of increase for those diagnoses. And we see, so we've plotted nursing homes rates of change for antipsychotics here on the y-axis, and then we've plotted their concomitant rate of change in antidepressants on the x-axis. And we don't see much of a correlation between the rate of change between these two indicators. However, there was a small correlation between the reduction in potentially inappropriate antipsychotic use and the increase in trazodone. So basically what this number shows is that nursing homes that had greater declines in antipsychotics showed greater increases in trazodone over time. And this suggests possible substitution between antipsychotics and trazodone, where there is a replacement happening in the nursing home. We saw a much stronger correlation with the relationship between the change in potentially inappropriate antipsychotics and the change in those relevant clinical indications, such that nursing homes that showed greater declines in potentially inappropriate antipsychotic use over time showed quite greater increases in those diagnoses, and things like delusions, for example. So you can see here that this nursing home here that had one of the largest declines over time in potentially inappropriate antipsychotics had quite large increases over time, well above average in terms of their rate of increase in those diagnoses. So this really, again, supports that conclusion that there have been these changes to the way that certain diagnoses are recorded as a result of efforts to reduce antipsychotic medications that could have unintended effects. So in this case, for example, this nursing home down here that shows large reductions in antipsychotics, if you only looked at their antipsychotic rate, you might think that's due to deprescribing, but it actually could be driven by just changes to the way that certain diagnoses are coded. So the last study I'm going to take us through today is now estimated at the resident level. So the first study looked at population level trends in psychotropic medications and those relevant diagnoses overall, and then by various subgroups. Paper 2 was looking at how those trends vary across facilities, and we saw a large variation, particularly in the coding of diagnoses across facilities. Now, this study is looking at now the level of the resident, and it's looking at resident level patterns and medication use over time. And the goal here was to look and to consider whether prescribers now, instead of initiating antipsychotics, may initiate trazodone, for example, for dementia-related symptoms. So if you had someone present with dementia symptom in 2010, where someone may have initiated an antipsychotic, maybe in 2017, they're initiating a trazodone. So what we did is we identified a cohort of new admissions to long-term care in Ontario. We ensured that they were off an antipsychotic and antidepressant at the time of admission. And then we followed them forward to see which drugs were getting initiated first. So in this case, we followed someone forward to see whether they initiated, in this case, they initiated an antipsychotic, followed this person forward across their assessments, and they initiated a trazodone, and this person remained off drugs. Now, the goal here was to see how does this change the treatment pattern and treatment in which drugs are started. How does this vary according to when you were initiated? So as I said earlier, you might anticipate that if you were admitted earlier, an antipsychotic would be more likely to be initiated first. But this may become less likely after these antipsychotic reduction efforts that really took hold in Ontario in 2014. And then you might see trazodone kind of take the place. So this is medication substitution via which medications are initiated, as opposed to switching a particular resident from one to another drug. So here I have two figures. On the x-axis, we just have the year of when someone was admitted to the home. So these are folks who were admitted in 2010. And on the y-axis, I have the relative rate of initiating antipsychotics in yellow and trazodone in purple. And this is all relative to people admitted in 2014. So someone admitted in 2010 were about 35% more likely to be initiated on an antipsychotic compared to someone who was admitted in 2014. But someone admitted in 2018 was about, let's say 23% less likely to receive an antipsychotic compared to someone in 2014. So we see a clear shift in which drug you're more likely and less likely to receive depending on when you were admitted to the nursing home. Now, when you look at the overall population of nursing home admissions, we see that the rate of antipsychotic initiation significantly declined. All these confidence intervals are lower and higher. So they're higher in this early period relative to 2014, and they're lower in this later period. You can see trazodone creeping up over time, but the incidence for the overall population remains actually quite stable. Where we only see a change is among residents with dementia, where we see that residents with dementia, if they were admitted in 2010, they were significantly more likely to receive an antipsychotic relative to a resident with dementia admitted in 2014. But you can see here that a resident admitted in 2017 with dementia was significantly more likely to receive a trazodone and significantly less likely to receive an antipsychotic. So this is a potential unintended consequence in which drugs that prescribers are initiating. So due to pressure to reduce antipsychotics, folks may now be starting a trazodone, for example. And there is some evidence to suggest that trazodone has a lower risk of mortality, for example, among residents with dementia than antipsychotics. But there, the evidence base remains quite sparse for these medications, particularly for their effectiveness at treating PTSD. And these drugs also have other side effects. So there's also kind of a similar risk of falls associated with trazodone, for example, due to their sedating properties. So this is just one mechanism in which drugs could be substituted, which is again how it's the kind of initial treatment decision. So a kind of summary of the evidence of the 3 studies that I've taken you through today, the high-level sentence is that there is evidence that antipsychotic medication substitution and changes to diagnosis coding are occurring as unintended consequences and effects of efforts to reduce antipsychotics in long-term care. And this is important, again, as I mentioned earlier, because the potential substitution medications that are used in place of antipsychotics really lack evidence of efficacy. They lack evidence for safety. And also they could be, actually, advances here. So yeah, so these medications lack evidence for safety and effectiveness. But also in terms of the public reporting programs, especially in Ontario, the increasing use of medications like trazodone or gabapentin could be missed, and that's because we're just not tracking those drugs. In the US, I do know that sedative hypnotics are getting tracked, but there's been work by Moust and colleagues and Gerlach and colleagues that show increases in other medications as well, like gabapentinoids. So it's a bit of a game of whack-a-mole to some degree, which is kind of the focus of today's talk, and that when you try to kind of tamp down one medication, others can pop up in its place, and it's important to anticipate those potential increases. But my last point is just to kind of say that measuring facility quality is also more complicated than just measuring the prevalence of folks who are receiving an antipsychotic medication. Oftentimes, medications do have net benefits for many residents in long-term care, and I think we need to think of a better measure of how to weigh those clinical pros and cons. And there's been some work in Ontario that shows that the duration of antipsychotic use may be a better indicator. So instead of just having a binary indicator of whether someone received an antipsychotic, it would be more so how long was someone on an antipsychotic, and is there a way to kind of reduce use as opposed to just having use versus no use. So thanks everyone for coming today. It's always a delight to talk about my PhD research, so I appreciate it. And I have about 5 left. I banked, I think, 6 minutes left for questions, should there be some, but I wanted just to quickly highlight my doctoral committee who are all up in Canada, as well as the various funding bodies that help to support this work. So if you have questions, we have 5 minutes or so, but I have a few other slides from the QIO that we can go through. But you're more than welcome to email me, and we can chat more.
Thank you, Dr. Harris. So if folks have questions, please pop them in the chat.
So Mary Ellen, if I might say something. I've had the pleasure of working with Dr. Harris in the past before he went off to Toronto and do his PhD. We did some great work in the nursing home here in Rhode Island. And I'm so proud of the work that he's done in Ontario. And I just wanted to emphasize that even though it was done in Canada and in Ontario, I'm biased, I'm Canadian, but it's great work. It's completely relevant to what we're seeing here in the US. And even though there are some differences in terms of the way nursing homes function in Canada, the principles are essentially the same. You know, we're all trying to reduce antipsychotic use, but we're also trying to figure out if what we're doing is, you know, in the best interests of the residents. And you know, changing a diagnosis is not in the best interests of the residents. And you know, I still worry about whether changing to trazodone is a good thing or not. And I'm guilty of doing that on multiple occasions. I admit it. Certainly try not to move to benzodiazepine, but I'd love to see some of the evidence related to that. And just as a reminder, I'm going to send in a reminder in chat that in a couple weeks, we're going to discuss in further detail with the pharmacists for trazodone and benzodiazepines. So we can really, maybe all of us can have a better sense of if we're doing the right thing for our residents or not for these alternative medications to antipsychotics. And we'll also talk about the newer antipsychotics at a separate session. So this is a conversation in progress, and I'd love to hear your thoughts, anybody, about if you do actively switch people to trazodone, and what you think about it. Is it a good thing? Are you worried about certain things? I certainly worry about falls, and I also worry if it's doing anything. And how do I know if it's doing anything? And that becomes difficult in different circumstances as to relying as a physician, I'm a geriatrician, if I'm relying on the nursing staff to give me that feedback. It can be very good, whereas I rely on the nurses, or it can be a little bit of a black box where I'm not sure what's going on. So I'd love to hear some thoughts from people.
Feel free to take yourself off mute. We'd love to hear from you, or pop a question in the chat. It is, I would say it's a really very compelling discussion, and I would think, Lynn, more so with the pandemic. I know that this has been an area of great concern prior to the pandemic, but it seems like, you know, we've all been a bit off kilter for a lot of different things, and this is one of them to try and get back into addressing, and even more so now with just what we've seen from the long-term effects of COVID.
You know, I do see a question in the chat by Brandy Cunningham. So thank you for your question, Brandy. And I'll just quickly add, Mary Ellen, there is actually a lot of evidence in Ontario that shows an increase in antipsychotics following the pandemic. So as well as drugs like opioids and gabapentin. So it's been just a general increase. But so
Sure.
Brandy asked if there are any studies on for in particular residents with dementia and BPSD or other mental health conditions, and how it can be challenging to kind of care for these folks without the use of antipsychotics. So this is a terrific question, and it speaks to, again, a broader issue of how we measure antipsychotic use and the appropriateness of antipsychotic use within the true real world clinical context. There has been some work by Moust and colleagues that looks at residents with, I believe, bipolar conditions, because those that is an indication for antipsychotic use, and there was some concern that these efforts to reduce antipsychotics might then sprinkle over into patient populations that actually can use and benefit from the drug, and they actually found no decrease among this group. But you raised important questions about other clinical subgroups, such as residents with other complicating mental health or comorbid mental health conditions. And I think, again, defining appropriateness in those contexts is challenging, and then to have that be consistently implemented within a federal or kind of policy framework is even more challenging. I see another question. Sorry.
Sorry. And there's a question, I think it was directed to me, but it's for you.
Okay.
Was it a primary care doctor or a psychiatrist that prescribed these meds most frequently?
Another good question. So these were all physicians who work within nursing homes in Ontario. So what their particular training was, we don't know. We didn't pull those data, so we don't know if they were trained as geriatricians or they had other training. But all of these were prescribed in the nursing home setting. To Lori Cunningham, it's generally low-dose trazodone is prescribed.
Great, we love questions. Any more questions for, and don't be shy if you want to come off mute and ask, that's great too.
And it's particularly low-dose trazodone because trazodone is so sedating that at therapeutic, so like for at therapeutic doses for depression, I mean, it would just be such a high dose, right? And Lynn, I'm sure you know, you can talk to this, like it's such a high dose of trazodone that people would just be put to sleep. So yeah, and there's a study by Iaboni and colleagues published in 2016, I want to say, that showed the largest increase in low-dose trazodone.
Well, great discussion on this. Again, if folks want to put questions in the chat, feel free. We'll just mention that we have some upcoming education sessions. If you know of colleagues that missed today's session and want to hear it, it's being recorded and will be replayed tomorrow at 3:30. The link, I put the link into chat. Our IP3 series is on Thursday at 11 o'clock, and we will be talking about the updated interim COVID-19 guidelines for infection control, and highlighting some things specifically for the long-term care setting. So that is on Thursday. Also Thursday at noontime is the 4th session in our emergency preparedness series, which has been hugely successful. So if you can join, they've been very, very compelling sessions. And this one is going to concentrate on the media at your door. What do you do when the media is at your door for a disaster? And next slide, please. And we have mentioned this coming up on May 18th. We are presenting a all-day session, well, a three-quarters day session, 9 to 2:30 p.m. on the 18th, talking about the top 10 deficiencies for long-term care. These are the F-tags that we will be talking about. So there are 30-minute sessions for each topic. So you can join all of them, or you can join the one of most interest to you, but they'll be starting at 9 a.m. If you're high tech, I am not, you can scan the barcode on your screen. I've also put the link into chat, so we hope to see you there as well. Next slide. I think it's the last slide too. Oh, no, this is second to last. So was today's program a good use of your time? Is there something from today's program you can use in your daily practice? If you could answer yes or no in the chat, we really appreciate your feedback, because this guides our education planning. So thank you guys for your feedback. And I think the last slide, Dan, is next. I was right. This is our contact information. So depending on which state you fall into, all of us here at iPro QIN-QIO are here to help you with resources and education. So please reach out to us. And with that, I don't see any more questions in the chat. So Dan, I just want to say thank you so much for presenting. This is such a timely topic, and I learned a lot just listening to you. There's a lot to know about it. So, and the conversation, as Lynn mentioned, will continue with this series. So we hope that you can join us again next week.
Oh, I'd love to. Thanks so much for having me. It's been a lot of fun coming today.
Okay. All right. Well, with that, we can close out, and thank you, everybody, and see you next week.
All right. Bye, everyone.
Thanks, Dan.